professor, initially in Southampton University, then moved to Brescia University, then, inshallah, to Jordan University. Professor Abu Hilal is well known in minimally invasive surgery in the field of hepatobiliary. And he is an author of more than 250 publications worldwide in a very prestigious journal. We are privileged to have him in Jordan. And today, his talk will be about challenges, managing challenges in minimally invasive hepatobiliary surgery. Please, Dr.
Assalamu alaikum, good morning, ladies and gentlemen. Thank you very much, Mr. General, for the introduction, and thank you, ELSA, for this kind of invitation, and thank you, Marcus, for thinking to invite me to talk about this interesting topic, challenges in minimally invasive surgery. My conflict of interest is that I am one of the people who have pushed so hard to expand minimally invasive HPV surgery around the world, that my talk today will be a little bit contradictory, because it will show that it is not something that people should be pushing for unless they are well prepared, and that it is not really something that is always for the best interest of the patient, but specifically it's not something always for the best interest of the patient. I hope you will enjoy it. So, So, what are the challenges? So, the challenges are something which we encounter every day. There are the difficulties that the surgeon can encounter during his surgery. And HPV surgery, for who does liver resections or pancreatic resections, is something full of challenges. And it is not a problem if you have challenges, because this is part of our practice, but it's a problem if you don't manage the challenges, because every challenge that you don't manage can turn into a morbidity or a mortality. And it's essential that you manage all your patients and the challenges you encounter with your patients in a good way, otherwise you will have bad outcome. So the surgeon in the UK, they tell us that the surgeon should be a surgeon, a teacher, an academic, but also a manager, and the surgeon should be a manager. So this morning I came with this hard disk to present my talk, but then I realized that I took the wrong hard disk. So I called my wife, she sent Uber, and she sent me the right hard disk here. So that's management as well. The biggest challenge that we encounter during our surgeries is linked to bleeding, especially in HPV surgery. And I would like to focus on bleeding on this talk, just to give you a flavor of how challenges can be, and how challenges can be important in the short term and in the long term to your patient. This is a study where we looked at resections of liver resections, complex liver resections after portal vein embolization. And what I want to show you here, that bleeding was one of the most important things, whether it's in laparoscopy and open, but more importantly, I want to show you that the conversions in these procedures was more linked to bleeding, but more importantly here, you will see that in the converted cases where there was a challenge because of bleeding, we have a significant blood loss and a significant transfusion rate, but also the mortality in these patients that you convert because you were not able to manage the challenge goes from 2.7% to 18%. So if a surgeon doesn't manage this bleeding nicely and convert the patient, you are increasing the mortality of this cohort of patients by 9-fold. And this is significant. And if I want to give a message from here, it's better that a surgeon does an open resection rather than doing a minimally invasive resection laparoscopy. This is another study which is important, looking at the impact of emergency conversion compared to elective conversion. Elective conversion is when you put a scope in and you find a lesion, then you convert. That's an elective conversion. But if you have a problem with the vena cava or with the portal vein and you convert, that's an emergency conversion. And look at these results here. It's laparoscopic and global. So this is the most important slide where I will start. So this is comparing the emergency conversions with open surgery. So in an emergency conversion, you lose 800 of blood, but if you would have done it open, you lose 300 ml of blood. And the transfusion, etc., and the major blood loss is double. But the operative time is also double. The severe morbidity, if you do an emergency conversion, is double. And the length of stay and this, etc., didn't change or did change, but it's not statistically significant. While if you compare because of an elective conversion, there's no big problem. So emergency conversions are really a big problem. And it's the same when you look at distal pancreatectomy, it's the same when you look at pancreatic lumpectomy. And I will skip because I noticed that. So this is the risk of conversion also during robotic and laparoscopic pancreatic lumpectomy. You will see also that the majority of the conversions are due to bleeding. And then here I want just to confirm to you that bleeding is our major problem. And when there is a bleeding, the surgeon is under a major challenge, and he has to manage these bleedings in a good way. So the surgeon is a manager, or the surgeon should be a manager. I come back to the first slide. Because in certain cases, or in certain moments of these procedures, when you have a real need, you have to manage not only the case or not only the patient challenge, but you have to manage yourself, your stressful moment, and you don't know what happens to a surgeon when there is a hole in the vena cava, especially if he's working laparoscopically. You have to manage your team. Your nurses who are looking at blood pouring from somewhere and don't know what to do. You have to manage your assistants who sometimes they are not as experienced as you. And you have to manage the anesthetist who will start acting by himself, feeling the patient, and maybe he doesn't have to do that, especially in liver surgery. His confidence, he will be looking at you. So you are the pilot there, and everybody looking at you and hoping that this airplane will not crash. So this is why a surgeon should be really prepared to the challenge and be prepared to enter in the world of minimally invasive surgery with a specific vision and the mindset, understanding that this is really a challenging field, especially when you do minimally invasive surgery. It changes your lifestyle. When I do a laparoscopic pancreatic lumpectomy or whipple, I learned by time that this is the day when I go home and sit in the sofa and sleep at 5, 6 o'clock, that there is no way you can go out for dinner, and by time even your kids and your wife start understanding there have been a laparoscopic whipple. And they never understood why this is happening till I show you later why this is happening. However, if you want really to do it, you do it, but this is with a specific goal. Again, guidelines have said that conversion is a big problem, and guidelines, other papers have shown that if you convert and if you don't manage these bleedings, you will take the patient to mortality. So it's important to avoid these moments, but also if they are happening, to manage them. So we're working here between risk mitigation and risk management. To be able to mitigate risks and to reduce their things, my advice is to surgeons that they have to enter theater as the king of that theater. It's the only place where you can be the king. Because at home it's the wife who's the king, everywhere else somebody else is the king. But there you have to be the king. And you have to have ownership of everything, including the operative field, including the patient, including the theater. And to be able to do that, you have to have a wide clinical knowledge, but also specific knowledge about your specific case. When you enter, you have to see all the operative field, and when you are working or not, then you have to own the operative. So, for example, this is a case which I'm showing you where we make a pancreatic lumpectomy in a patient who have an accessible right hepatic artery coming from the SNA. A normal abnormal anatomy. If you know it, you can deal with it, you can prepare it beforehand, and you can be careful about it, and you can make your operation even easier. But if you don't know about it, and I can tell you, I've seen expert surgeons in open surgery ligating the right hepatic artery because they didn't look at their scans well, they didn't examine the patient well, they didn't bring their scans with them to theater to be able to look at it and examine it while they are operating. And these are the never again incidents that can really make a death. So if you know the patient, if you know the anatomy, you will go to the place. The surprise to the surgeon, to the excellent surgeon, is challenged only by the surprise. If you have a surprise, you lose. But if you know what you are going for, you can win whatever is the challenge. So bleeding can happen from the most easy things. This is a case where we were putting with one of my fellows just to start the operation, and this is a retractor which can cause, this is small, stupid bleeding, but can be annoying, and you don't know how much the performance of the surgeon can deteriorate with just a little bit of small bleeding, just because of the humor of the surgeon can change unless he can manage his feelings and his other bleedings can happen because maybe you don't understand the physiopathogenesis of what you are doing. This is an extended left hepatectomy. It takes about 5-6 hours. When we do liver resection, we empty the patient. We work in something called low volume surgery. And when you have done this great operation and you are happy, you take the specimen out from the fenested incision, and the anesthetist who was keeping excellently the patient surviving on 3 liters of circular volume, he starts filling him with water and with saline. Also, you take the specimen out and there's no pneumoperitoneum. So a small hole in the vein, which wasn't seen before, when you start pouring blood, you come back and you find that the patient has just 2 liters of blood. So you need to know what you are doing and be careful that you are going to encounter things like this. And the bleedings can happen in different scenarios. I'll show you some of them. I have done something more than 1,000 laparoscopic resections. So if I show you 10 cases, don't think I am rubbish, but these are things that happen. It's very, 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 very rare. This is in 2008, a right-hand hepatectomy for a lady with a huge bleeding adenoma. Here we have a bleeding from the right hepatic vein. It's an important bleeding. If you convert this to open surgery, the big risk here is the gas embolism. The gas embolism is occurring here, but it's occurring from CO2, and CO2 is an absorbable gas, so it doesn't matter really. Quickly it will go. But if you open and the patient sucks oxygen in from a big hole, then there is a problem. So to manage this, you need to be able really to suture this thing, and these are difficult angles, and this is 2008. These were one of my really first 2-3 years things, so you can see even the tension here. And the only way which can take you out of the problem is this. This is one of the fellows who is doing a left hepatectomy, a left lateral sectionectomy, and he made a hole in the vein. Again, this is a very difficult position, and you need to be able to suture in very difficult positions. And here I'm showing you 3-4 videos just to confirm that if you want to do this extreme surgery, you need to be able to suture laparoscopically. Because if you can't suture, you may run into gas embolisms and death. And not only the fellows, this is me in 2013 doing a segment 7 resection to a dad of a third-year medical student who have a segment 7 coronary section, came from Oxford because they told this couldn't be done laparoscopically. And look at the hook here, the tip of the hook. I use the hook at 30, 35, but when I go in veins, I take it down to 20. I forgot to take it down to 20 here, and the tip of the hook fires directly in the vena cava. And here again, it's not a very big hole, but it's a serious hole. Gas embolism can occur, and the only way we can deal with it is by reducing by mobilizing it and by suturing. So suturing, whether it's an open, laparoscopic or robotic, continue to be the most important skill that the surgeon should have. So if you want to do extreme surgery, whatever is the specialty, you need to be able to suture. Because if you can suture these, then things can go better. Now, this is the biggest challenging case that I had in my career. I was doing an extended right hepatectomy in the patients who had portal embolization and there was a lesion in segment 8 where you see the grasper, and I was trying to separate that tumor, lifting it from the cava, something that I do normally, but because of some adherence, I opened it in a cava. I wasn't sure, so I opened it again. So here really, there is no way you can suture this. And the silence which was in theater when everybody saw this call was incredible. And normally fellows would come out with suggestions, but this time nobody came out with any suggestion. So there was some gas embolism, CO2. So I said I'll put a piece of hemostatic product in the vena cava just to block, so to think what I'll do. So I started thinking, look, let me go ahead a little bit with the resection and maybe see the hole from up and try to suture it. I wasn't really clear about the topographic location of that hole. So I started working, but the tension in that theater between anesthetists and assistants and nurse was so great, so huge. And in these moments, you have to show the more coldest blood you ever had in your life. You have to be as calm as possible and trying to reassure everybody why you yourself, you don't know what's going to happen. Because there's a hole in the kidney. If I open, I really here have a big risk of death. So I went up to see it again, because surgeons can't keep still. They say, really, there is a hole? Yes, there is a hole. So we keep putting this, and what I've done in this operation is that I carried on trying to open the liver to see the hole, but then I found myself that I finished the operation nearly, and what I'm left here is with right hepatic artery, the right hepatic vein. So I sutured, but we still have the hole. So I prepared for a laparoscopic suture in this case, and it's the vena cava, and the only way that you keep still and you are able to suture that vein laparoscopically without losing too much blood, without having problems. So we managed to do that. I could have reduced that spit of blood before by stopping the distillation, which I didn't, I forgot, but now you will see that here there's no bleed, so we want some blood to come out to vent, just in case there's a clot or a piece of the snow there. So I asked the anesthetist to do him up. And this is how we manage this case. So the management is not that suturing in this case. The management is going ahead for 3 hours, 3 hours and a half for an operation when you don't know what will happen at the end, and being able to keep everybody quiet. This is what I'm talking about management. So, in pancreatic surgery, a lot of problems can happen. This is during the weekend. From the easiest thing, you can really, you didn't do anything, and you have a bleed, and it's arterial bleed. So in this case, you need to be able to suture, to be able to carry on and finish your operation. And again, the difficult angles that you are suturing in are the most important. This is why somebody who wants to do this surgery should train on difficult suturing in different operations, like incisional hernia repairs where you have to suture in this way, etc., etc. So this case was managed like this. But look here, the unlock. So we are working on the portal vein. The portal vein is the worst vein that you can encounter in your career. And here the unlock is that the hemolog just gets stuck to this, and you have the portal vein. So unless who does this surgery knows that you have to stick the portal vein above and below to be able to suture. It's a high tension vein. So what I did in this case, I put some snow, I put this, and they said, let me control the vein up and down to be able to suture it. And this is what I've done. So went above it, sling it from down, sling the artery. I wanted to sling the SMA also to reduce the thing. But then when I went to see the bleeding after I controlled the vein, there was no bleeding. The snow, which is the hemostatic product, has stuck to the hole. And they said, let me carry on with the procedure. This was a total pancreatectomy, total pancreatectomy. So we carried on with the procedure with that, and the bleeding was not there. So, and this is the splenic artery divided, and this is the pancreas. I did a total pancreatectomy, preserving the pancreatic artery and the pancreatic vessel, because this was an IBNN on the head, degenerated, but on the tail it wasn't, so there was no need to take the spleen. And I kept looking for that bleeding, and it kept stopping, so I went onto the lamina of the pancreas, taking the oxidative process, and this from the superior mesenteric artery, kept looking at the site of bleeding, and there was nothing I mean, if I didn't cause the bleeding, it wouldn't happen. So I put snow and I put another product, which is a hemostatic product. And in this case, we managed to finish this operation without having to suture that vein. Sometimes if you suture in these veins, the needle hole will cause more bleeding than anything else. So I show you a number of important cases which we manage the bleeding and everything looks beautiful. But what happens to you as a surgeon when you are dealing with these cases? I ask myself always this question. I ask myself why after we sleep at 6 in the evening. There was somebody who said that minimally invasive surgery takes the stress from the patient to the surgeon. And being an academic, I like always to prove this by numbers. So this is a study which I started doing about 4 years ago, where for every operation, I put myself a halter, open, laparoscopic, big surgeries and small surgeries, and we monitor the patient catecholamines and heart rate, and we monitor myself heart rates and catecholamines as well after the procedure. And we've been testing this for about 60 cases when the EAS invited me to give a talk about challenges. So I wanted a video, but the researchers wouldn't let me because it's a blinded study. So I said, the next study, please. The next studies, don't put them in the project, and I want to know what's happening. So I realized that as soon as I am working on a wither, my heart rate is 97 instead of the normal 72. But look here, I realized that when there is any challenging moment, this is a wiggle after neoadjuvant chemoradiotherapy, advanced advanced cancer. Look at the heart rate and look at the screen, and as soon as you see blood, what happens? Your heart rate jumps to 118. And look now, if you don't see blood, it goes down a little bit, but as soon as you see the red color, like a bull, it goes up, and now you have to deal with this bleeding and suture it. So I have to suture it to be able to carry on with the procedure. Now you don't see blood, it's 8. I put the first stage, it goes down a little bit. I take, there is blood, it goes up, and it continues like this till you finish and you control the bleeding, then you go back to baseline. Baseline is 97 in the laparoscopic Google, I realized. And I can't tell you all the results, what happens in robot, what happens in open, because the study is to be published, but the worst thing you can do is working around the portal vein when it's bleeding laparoscopy. Also, robotically is not that nice, it's also bad, but not as this. And you finish, you go back to normal. There is no blood, you control it, you go back to normal. I wasn't aware of what's going in my heart. People who are behind me know, you go back to 96. And for 6-7 hours, your average heart rate is 97. So if you want to lose weight, you go to the gym and your teacher or your trainer will tell you have to do aerobic to get your heart rate 30% above the normal to lose weight. And this is why most of us HPV surgeons or surgeons are thin, because this is the exercise we do for 6 hours. This is the answer to who tells me at home, you eat 3 times more than us, but you are like this. Yes, because this is what we do. Look here, the vena cava is, to me, or to Dr. Smart, if you ask me, say, what is more dangerous, the vena cava or the portal vein? He tells you the portal vein. So the perception that the vena cava is less dangerous, even when there is a hole in the vena cava, your heart rate will not go to 108. It will go to 108 because you know that the vena cava is forgiving, is much more forgiving than the portal vein. And there is a link between your perceptions and experience with things, how they are, with what happens to your heart. If you do a laparoscopy or appendix, your heart rate is normal. It doesn't change. So I present this study when it's published, but just to give you a hint of what happens to the surgeons when they are dealing with this. And it's important that people who want to undergo in this field or people who want to push in this field are aware. I have a few colleagues in America who are waiting this publication desperately. And Rachel keep asking me, when you will publish this more? I need it. I said, Rachel, why are you so interested in science? No, I just want to take it to the manager of my hospital because I will get a pay rise of $200,000 for that. because I want to show them what we. So even healthcare systems need to start understanding what we are going under. I mean, it's impossible that we are paid the same like dermatologists in the hospital if we having this and if we are losing a lot of money. So if we come to conclude, I will take you back to physiopathology. In physiopathology, you remember the Laplace law. The Laplace law was saying that if you have a thick elastic, I'll take you to this slide. The thick elastic compared to a thin elastic, you can string it as much as you can, or you can string it more. It can tolerate, because the diameter can help it to tolerate more tension and pressure on the surface before exploding. If you remember the ventricle physiology, etc. So more thick is the elastic, more tension, more pressure he can have inside and outside before he explodes and have a breakdown. And in Italian or in Latin, the diameter is the caliber. This is why you say this is a high caliber faculty. High caliber means of high diameter. So if we want to do a little bit of imagination, the caliber of the surgeon, which is the diameter of the surgeon here, is what is not his stomach, but is what he built of experience, of skills, of knowledge, of character, strength, and bravery that helps him to prepare to change, to face these challenges. Because if he doesn't reach this point, he will break down like what will happen to the yellow slave. You want to be this, not this, before doing this surgery. And this can happen through training and preparation. In conclusion, ladies and gentlemen, minimally invasive surgery is challenging. Minimally invasive HPV surgery is full of challenges, and the surgeon need to be able to navigate through these challenges nicely so they don't become really deaths and mortalities. And surgeons, health authorities should know what stress we are exposed to, and the breathing continue to be the tender of apple for all surgeons. And surgeons should have a large portfolio of skills, tricks to be able to manage these so they can take things to an important end. These are the lessons that you can learn from my mistakes, from my experience. And the only mistakes in life are the lessons that you didn't learn. This is what says Einstein, but what I would say even more are the lessons that you didn't attend. So you have to attend the lesson, not only to learn it. Because if you don't attend, you don't learn, and if you don't learn, you don't learn. Thank you very much.
Thank you, Mohammed. We're going to leave the question to the end of the session. I'm sure we're going to have a lot of comments on this interesting lecture. So allow me. Allow me to present Dr. Mohammed Khadri. He's an Attorney General and gastrointestinal surgeon specialized in laparoscopic robotic and oncosurgery. Work in practice in Ankara Bilkent Hospital. He's gonna present to us robotic mobile how to do it. Thank you for coming up.
It's me again. I want to tell Dr. Mohammed Hamida that while I was watching your videos, I had two heart attacks here on there watching you. So thank you for a miracle. And I will show clean here for robots without bleeding a smooth one. I prepared for this, you know. And again, we were in a truck, and my little daughter, Dennis, her name is Dennis, it's very admirable. He was looking at with short eyes, so it was really memorable moments. Before beginning my speech, I want to tell that I'm a gastrointestinal surgeon, which includes upper GI, lower GI, and then HPV surgery as well. But I find myself as a minimally surgeon, but given this, while I'm talking like this, the pancreas surgery is a little bit different because I still see myself and not the liver, minimally was liver or minimally was pancreatic surgery as well. Not competent as well. While I'm talking this, I'm not trying to be humble because I'm talking with the facts. A recently published paper tells that if you want to be competent in robotic liver surgery, you must perform at least 63 surgeries. This is a high number to HPV surgeon as well. But if you want to be if you want to talk about the proficiency, if you want to be proficient, this means that I'm doing the surgery without any tachycardia. You must perform at least 150 cases, robotic cases, and this is a huge number. And the same paper says that if you want to master in robotic liver surgery, you must perform at least 250 surgeries, and this is not a number that I can reach in my lifetime. So I still see myself not competent in the minimally invasive pancreatic surgery as well. But I will tell you how we perform this surgery in our unit. The quartz placement is similar as the robotic total gastrectomy because organs is the same place. So we place all the four ports and the assistant port in the horizontal manner in the clinical slide, horizontal. This is the patient position. Actually, it's still the same with the robotic gastrectomy. The patient is standing 15 degrees, reverse triangle positions, all the legs and arms closed, and the robot approach from the right side of the patient. And we use the same instruments that we use in the robotic gastrectomy as well. In the first arm, we use bipolar forceps. In the second arm, we use camera. In the third arm, it's changeable. We use energy devices like hook, scissors, or vessel sealer. And in the fourth arm, we use tip-up forceps for contraction. And I will start the video. As I told, first we enter the instruments inside of the patients after we make the docking, and with bipolar forceps, tip-up forceps, and energy device. Firstly, we start entering the gastrointestinal area, opening up and seeing pancreas walls. And like with the open course, like with the open surgery, we start with making a cavern, but before it, we use the gallbladder itself to hang the liver outside. So we open the area that will work during the surgery. We liked a huge coher maneuver to make the pancreas at outside free. We work downside of the duodenum and open the tissue here to make a huge coher maneuver until we see the renal vein here near the vena cava. This is a patient of small pancreatic cancer in the head of the pancreas, and we in the open procedure as well, we first make the SMA first approach. We first identified SMA, and this was the root of SMA. And we open it first. We dissect the area over it, and this shows up that the SMA first approach helps that the other times of the operation will be less, you will see less hemorrhaging, and in the first place of the operation, you will be sure that the tumor is not invaded to the artery itself. So, under the duodenum, with making the coher maneuver, we see the renal vein, and after that, we identify the SMA. Hang it, free it, dissect all lymphatic tissue around. Of course, there will be small arteries, small branches that will go to the pancreas itself, and we ligate and divide and cut it. After making the SMA first approach, different from the open procedure, we first divide the stomach to open the area of the pancreas to work freely over it. From the greater curvature side and lesser curvature side, we open the area for the section of the pancreas and section of the stomach, and we divide the stomach with the help of the step. And after that, Similar with the total gastrectomy, we start to make the lymph node section around the hepatic artery. This is the station 8A. You can see the increased size lymph nodes here, and we hang the hepatic artery to help us to get the downside of the lymphatic tissue as well. After that, we carry on to the hepatoduodenal area, and we will dissect all the lymphatic tissue around hepatic artery, portal vein, and main bile duct. As you can see, this is the gastroduodenal artery here. We identified it, dissected tissues around it. And we will clip it and cut it afterwards. After also, like the hepatic artery, we use the root of gastroduodenal artery to hang the artery itself to make the area much more clear. The downside, you can see the portal vein now, and we will carry on to dissect the lymphatic tissue around the portal vein as well. These are all the lymphatic tissues that we dissect around the hepatic artery and hepatoduodenal area. You may think that it's enough, but as you can see, if you carry on, there's a lot of tissues here, and like the open procedures we perform, we like to see all the tissues clearly around the hepatoduodenal area, like hepatic artery, portal vein, and main bile duct. You can see the lymphatic tissues between the main bile duct and portal vein. Then cut the main bile duct, take it to stand inside out, and cut it, and we will close the opening of the main bile duct with a bulldog. But during the surgery, some bile comes down and makes your area dirty, so we're closing it and taking out all the lymphatic tissue under the main bile duct also. As you can see, we take out a specimen of lymph nodes in the first place, but it was not enough. Even in the open procedure, the first procedure and this procedure, we do the same, and we make all the area clear. We take all the lymph nodes around the portal vein, hepatic artery, and in the hepatoduodenal area. As you can see, this is not enough. There is a small lymph node here in the posterior area of the hepatoduodenal area. So we also try to dissect it. Because we all know that all the occurrences, all the nexus comes, originates from this area, especially from the SMA side of the pancreas. And after that, we dissect this SMV and portal vein, turn down from the pancreas like we usually do in open surgery. We use the thorax opening to take the jejunum up. We divide the mesojejunum, and we will cut the jejunum with the stapler as well. We use white cartilage for this. We like to cut the pancreas tissue with bipolar because we want to identify the recent duct, because easily you can see the recent duct here. It is much more easier if you cut the pancreas with the bipolar device. And after cutting the pancreas, we start the section near the SMA and portal vein. This is the part of the surgery that I don't like, because there will be a lot of branches here that you will bleed and make your area, disrupt your area, make your vision very dirty. So as a minimal invasive surgeon, I don't like bleeding, and then nobody likes bleeding, but bleeding makes me like mom every last shows me taking cardio with me, so I want everything to be smooth. And this is the end of the section. You can see all the portal vein, SMA, SMV, and the hepatic And after resection, we start to reconstruction. As you know, in the open surgery, we start with the reconstruction of the pancreas first, but in the minimally invasive surgery, we make the cholecystectomy first, because if we make the pancreatic cholecystectomy first, we close the area of the main bile duct, and we cannot make the anastomosis easily. Avoiding from this, we first make the cholecystectomy, and after that, we perform the pancreatic cholecystectomy. The suturing of the main bile duct depends on the size of the bile duct. If it's wide enough, you can make continuous sutures, but it's not. If it is narrow, you must make one by one sutures to avoid the strictures in the near future. We use absorbable sutures for making anastomosis, and after finishing the cholecystectomy, we put a clean gas to see if there will be any leak while we were performing pancreatic cholecystectomy. Actually, we tried all kinds of anastomosis of the pancreatic cholecystectomy. We mostly make the receivable cholecystectomy. But nowadays, we start to use blue guard method, and as you can see, blue guard stores here. You can use any kind of any type of sutures, but in the first place, we now use absorbable sutures, but in this case, we choose to use a slip for the lumbar sutures, but for the cholecystectomy, we use absorbable sutures. We always, in the open manner or in the minimal invasive cases, we always use internal stents. This actually becomes a habit with the research. We put the posterior sutures, side sutures, and after that we put the anterior sutures. And when we finish the cholecystectomy, we close up the lumbar sutures over the pancreas. And that's finished. I know that I showed the smooth case, but actually it's not. It's every time it bleeds, every time something happens. After that, we don't forget to take out the gallbladder, and actually we use momentum or the phosphor ligament to close up the vascular tissues. And we believe that it makes the hemorrhage afterwards decrease. I will not show the gastric anastomosis. This is anastomosis that we usually do, so this is the intent. Thank you.
Thank you, Dr. Mohammed. We take the question till our next speaker will be Dr. Samir Samadi. He's senior consultant in hepatology and liver transplant. He was the chief of the general surgeon and hepatology department of medical services, and now he's working as a consultant in the Hussein Cancer Center. His outstanding work to push and to establish the hepatology and liver transplant surgery in Jordan is well known to all of us. Welcome to Sir. And he will present he will speak challenges in Jordan of advanced laparoscopic and prosthetic hepatology surgery.
Good measure. According to our Hilali criteria, it's like you don't have stress. Weight wise.
Actually, the stress coming from we are having a break just after a few minutes, so I will be quick, or I will be the imam.
No, I think to be quick is better.
Thank you very much. Actually, my talk will be addressed at the talk, not like always, because I'm another surgeon, I'm a hepatomegaly surgeon, and liver transplant surgeon. So my talk will be a little bit aggressive, not scientific. So first of all, just let me to extend my gratitude for all the guests and our ELSA, the chairman of the ELSA, to come to Jordan. Actually, I have the extended relationship with the Turkish surgeon since more than 20 years, and my first training was in Istanbul 20 years ago. Actually, Jordan is one of the small countries, but it's a coast country in the Middle East. And as you can see, is that the yellow one is for the guest. I think that our audience know where is Jordan, but we have around 90,000 square meter with a 12 million population, and still Jordan with one of the you can put it average per capita. And this is the reason why the manufacturer of most of the robotic, they look like to come to Jordan or to invest here in Jordan. Still, Jordan was the first country in the Middle East to start a cadaver law in 1972, and the first country in the region to start kidney transplant in 1972, and also the first country to start to have a cardiac transplant in 1984. The medical tourism to Jordan, you know that during the 20 years ago, Jordan was one of the elite places to attract the medical tourism to the area. And with just to give you a hint that Jordan in 2009, 2010 was ranked by the World Bank as the first country in the Middle East for medical tourism, and it was the fifth globally. And actually this ranking declined steadily during the next few years because of the instability and for the Arab Spring revolutions. So there we concentrate more on the security issues. That's why a lot of patients, we lose also medical tourism patients to the neighbor countries, namely Turkey. I was in Turkey in 2004, 2006, 2004, more 2 years of them. Jordan was, even Turkish doctors, and I think that you know them, Professor Yaman Tukat was thinking that he want to start in Jordan, because Jordan was an attractive place for medical tourism. I think that after 2010, we start to decline in this problem, and there India, Egypt, Turkey, both started to have better ranking than us after the problems which are created by the political instability of the Middle East. Still, Jordan actually, in the last year, the revenue of medical tourism was around 2.8 billion, which is we know that Jordan is not a royal country, but I think that this is one of the things which we can invest. We can concentrate up to have the medical tourism so as to just push the economy a little bit. Now, to those who are, to our guests, the health care organization in Jordan is having three sectors, mainly the public sector, which are the Ministry of Health, with around 30 to 40 hospitals, and the private sector, more than 40 hospitals, the non-profit like the Cancer Center and the University Hospital, which are two tertiary centers. All of those centers have hepatobiliary, mainly the liver transplant is not in two the centers, but all the centers have advanced hepatobiliary units, and they are doing most of the, if not all of the challenging cases of hepatobiliary surgery. And you can just, as you can see that we have the Minister of Health, we have 13 hospitals now, we give around 40, military hospitals now become 15 hospitals, the private sector, 61 hospitals, and just look at the private sector hospitals are flourishing, and there are a lot of patients from outside coming in. That's why the private sector is flourishing more than the government sector because of the patients who are coming for medical tourism. The University Hospital, of course, we have two university hospitals with two district hepatobiliary units, and we have those hepatobiliary surgeons. They are with us, and actually they are doing great job in hepatobiliary. So this we have around 14,000 beds in Jordan, and actually this is the King Hussein Medical City with 1,300 beds, and actually it has all the specialties and subspecialties from cardiac center to liver transplant unit, and actually this is one of the unique hospitals in Jordan. We have the King Hussein Center, and actually we just look at the numbers here. In 2022, we treated around 227,000 cancer patients. 1/3 of them were coming from outside. Although we consider King Hussein Cancer Center is a public health sector, still it's attracting about 1/3 of the patients are coming from the surrounding countries to be treated here. This just we can just this indicates that the reputation of such a prestigious center. Now, this is the Bashir Hospital, one of the district hospitals, the University Hospital, and the University Jordan Hospital in Amman. And these are the distribution. Those are the private hospital. Just example of the private hospital: the Arab Medical Center, Al-Aqsa Hospital, Jordan Islamic Hospital, Specialist Hospital, and Kidney Hospital. Also, we have more than 60 hospitals, the private and the state-of-the-art hospital actually. Jordan, actually, we have a lot of doctors who are training outside, and most of the time, the destination for training for many years was to the West, either England, USA. Just look at this: the Jordanian doctors achieved top scores in the USMLE and the American license, and we have, I think, more than 6,000 Jordanian doctors are working in USA. Some of them are coming back to Jordan, and when they see the situation here, because we are a little bit behind for robotic surgery, for advanced technology, and I think that if we can use those 6,000 physicians to improve the situation here in Jordan. Now I think that from 10-15 years we started to move our training to the Asian countries, especially Turkey. We started just maybe 20 years ago to start, and I think that we need to do this. We need to shift from the training to the West to the East. Because of the cost, because of the neighbors, of course we have state-of-the-art centers in Turkey, in Japan, in Korea. I did in Japan and Korea, and I saw that the improvement of the centers there and the opportunities which we can have from training in Turkey and the rest of Asia. Just to remind you that we started the liver transplantation program with the assistance of Turkish team, and in 2004 we started inviting the Turkish team. They did 2 cases here, and we were trained in Turkey. Then in 2009 we started our own program. So we did a lot of cases. This is the type of case which we are doing. We did first reported case of combined liver and kidney transplant on 2 million donors. And We are a member of the Pan-Arab Liver Trust Society, and we have two conferences here for the Pan-Arab Liver Transplant Society, and we always participate in the African and the international events for liver transplantation. Actually, when we are talking that, just I will show you some kind of cases which are a little bit different from what Dr. Mohammed showed us. This is one of the Sudani patients. I told you that we have a lot of patients coming from outside Jordan, from the neighboring countries. This Sudani patient, just to let you know that the magnitude of hepatocyte surgery which is done in Jordan. This is one of the cases. This is hemangioma. You can just see how huge it is. This is one of the also Syrian patient who was treated in medical center. This is also another hemangioma, and the difference actually from robotic and laparoscopic surgery. But from what Dr. Mohammed was saying, that when we are doing open surgery, although the patient will suffer after the surgery, but still we are able to control things easily before starting to have a high heart rate for the surgery. So you can just tackle, you guys see this, tackling the middle, left, and right hepatic vein before doing surgery, or tackling the IVC from above before even starting your surgery. And this, of course, more convenient for the surgeon, but I mean, definitely it's not convenient for the patient post-operatively. Everybody is aware of the benefits of laparoscopic and robotic surgery, and we will not just talk in this subject because we know the advantages of robotic surgery and laparoscopic surgery. And Jordan actually is offering a lot of laparoscopic surgery, and yet I think that they will be able to do this with robotic surgery. So we are just to let you know that Jordan is doing more than 12,000 of bariatric surgery annually, and we are one of the places where a lot of patients from the Gulf area are coming for this kind of surgery. All kind of chronic surgery, and particularly we started actually doing some surgery with the hepatobiliary, and our GM generation started doing lab web procedure, episiotomy, lab distal pancreatectomy, lab total pancreatectomy. But still, we are. I think that with the presence of the robotic surgery, things will be even much better. Kibuzik as a center started. Brought the CMR, and I think CMR a little bit inferior to the robotic surgery like Santorini or the Da Vinci, but a lot of surgery here at the young generation in Kibuzik as a center started doing surgery with the CMR, and I think that they are looking to this ELSA partnerships as to help us bringing the for other types of manufacture for the robotic system. What are the challenges? I think that the main challenge that for many years the manufacturer for Da Vinci, Santorini, and other types of robotic surgery, they were not willing to come to Jordan. I think that when they are looking at the income, the population of Jordan, they will think twice before starting to invest in Jordan. But I think that they don't know that the magnitude of the medical tourism which we are having in Jordan. So that's why for many years they refused to accept to bring the Da Vinci here. And I think that with the aim of such events, such conferences, is to have some kind of a relationship. So as we have Dr. Mohammed is the president of the International Laparoscopic Liver Transplantation Society, or Liver Society, and we have the ELSA, and I think they have some kind of relationship with the manufacturers of Da Vinci or other types of robots which we can use. The problem is that most of our surgeon generation who are trained outside, they are coming to Jordan and they cannot implement their skills, and they are frustrated from lack of the hand-on training, those regulation, either they will leave the country or they will have to steep down and start doing laparoscopy for complex surgery. So I think that we, as Jordanian, we have to start looking for the solutions to bring those robots to Jordan, to bring the expertise are here. I think that we need to have some kind of relationship with those manufacturers as well as to bring the state-of-the-art robots. So for governmental, I think that the governmental, for clinical cancer center, they started bringing the robot, but I think that for the governmental, no robotic surgery is done in neither individual cancer center or district. And I think that in conclusion, what we can say, although we are celebrating the remarkable achievement of preventive surgeon, still we think that because of the access of infrastructure, we have this barrier is compromising our improvement the level of robotic surgery. I think that we are just, in conclusion, we are asking all the stakeholder in our country, so as to have good collaboration with the international medical society, with the ELSA, so as to be able to buy those elite robots. Thank you.
We can open the floor for a few questions. First, any question regarding the lecture of Professor Abu Bilal? إذا في question تفضل دكتور بلال. تعال.
You mentioned that challenges about the degree of surgery in the benefit phase, actually, as you know, everybody knows that challenges is there either in open or in phase. However, in open, probably controlling the challenges might be easier. However, with the standardization of surgical technique and you are set as in charge in the theater, being as the clinical theater, with the standardization of surgical techniques. So I do this procedure this way, this. And commenting for everyone, everybody knows his responsibility to the theater. This is might be, do you think this will lessen or increase the incidence of vascular injury or minimizing the intraoperative stress? This is number one. Number two, it might be a comment that in the future, the augmented reality intraoperative are utilizing in the minimally invasive. Would you think this will ease and facilitate the proper procedure, or we will still have the same challenges in the theater?
Yeah, thank you very much. Two excellent comments or questions. First of all, I have to tell you that that video of the heart rate was in 2023. It was already since 2006, so we're talking about 18 years experience and standardization, and it was maybe the number 800 laparoscopic liver sections. So it's not like by time. I was at the top already, and it can happen still. Having standardized everything, having a team of excellent surgeons assisting. So surgeons who assist you in Italy are at the age of 60, have a team of senior surgeons. And despite this, these things can happen. The only thing which is different, if it would have happened in 2008, in reality, we would have had difficulty to do this. But the difference as well, that such a complex case, I wouldn't have done it in 2008, but I would do it now because I know. So It's a tool, standardization, improvement, having a team, all this can reduce risk, but the risks can't be zero. Augmented reality could help, yes, that's true, if we start having segmentation and interoperable navigation, so you will start, I imagine, running on the other screen and telling you this screen take care. I don't know if it will tell you exactly how thin is the wall of the renal cable, etc. It will help, of course, if you are going like this, it will show you a vein if you don't see it, so you, all this will improve, of course. But it will not take it to zero. These risks are there. The robot does improve something. The robot does improve the fact that people who don't have the switching skill very advanced can still switch it with the robot. And then risk of conversion. So in a lot of studies, if I will present you about 12 recent studies in practice and comparing robot to laparoscopy. We saw no real advantage. Absolutely, there are worse results, except for conversion. It does reduce the risk of conversion by 80%. So that's an indirect advantage to the outcomes of the whole group, maybe not to the specific cell. So this is a part of the augmented reality.
So I think for the sake of prayer, we're going to conclude our session, and we're going to thank the lecturer and the moderator. And I will conclude بكلمة حكاها جراح مصري it's a hibab video. السلام عليكم.
Currently, the moderators and the speakers of the first two sessions is present on the podium for honoring certificates. First, Professor Aziz Somar, Dr. Wael Hassan, Dr. Haitham Patel, Dr. Muhammad Qadir Cholakolo, Dr. Ayman Mandur, Dr. Riyad Abdel Jalil, Dr. Salam Daratka, Dr. Raed Al-Jarrah, Dr. Samir Ismadi, Dr. Ali Rabous, Dr. Muhammad Abdul, Now it's time for everyone to take a lunch break for 1 hour.
We will be back here in 1 hour.